Hi, I'm Dr. Tara Diliberto, and I'm reporting to you from Brooklyn, New York. I'm an assistant professor at Weill Cornell Medicine, which is the medical college of Cornell University. And I also opened and directed an eating disorders partial hospitalization program, or PHP, back in 2016 at New York Presbyterian Hospital. And this was a really important program for me because I wanted to create a space where patients with all forms of insurance, including Medicare and Medicaid, could get treatment from a multidisciplinary team. So our team at New York Presbyterian Hospital includes psychologists, dietitians, medical doctors, nurse practitioners, and a variety of mental health professionals, such as social workers, to help patients recover from eating disorders. And since 2016, things have changed a little bit. I've stepped down as director, and I now work in the program training doctoral and postdoctoral students in the treatment of eating disorders. And that's a role that I really love, and I'm very grateful to have. The reason why I stepped down as director is so I can work on creating and publishing a treatment that I created with Dr. Dina Hirsch called Integrative Modalities Therapy, or IMT, for eating disorders. And on August 1st of 2019, the book will be published, and here's a copy. Got an advanced author copy, which is kind of cool. So I've never vlogged before, and I thought that with this book coming out and with the kind of complexities that any sort of treatment involves, that it would be good to start a video series, this being the first video in that series, to help explain what IMT is and how to practice it. So what is IMT? IMT, again, stands for Integrative Modalities Therapy. Let's break that down. So integrative indicates that we have integrated lots of different kinds of evidence-based treatments and interventions so that clinicians can have all of those resources in one place at their disposal to administer them to patients that need specific interventions. So as you might be aware, evidence-based treatments and the protocols that comprise them are very linear and fairly rigid, and they definitely are able to be implemented in very controlled settings and not necessarily so easily adaptable to life in the trenches as a clinician working at a hospital or even in an outpatient setting. Patients very often have lots of comorbidities and need flexible treatment approaches so that clinicians in the trenches, for the most part, end up drawing on lots of evidence-based treatments, hopefully evidence-based treatments, or lots of treatments in practice to meet the needs of their patients. So what we've done here is we've created what we call an evidence-based practice model. So evidence-based practice, we'll go into that kind of sub-definition within what IMT is. So evidence-based practice means that you are, as a clinician, taking into account what the research says in addition to what the patient's needs are, what the patient wants, what the carer or parent's needs are, and what the parent wants, and collaboratively figuring out, given the resources available, what to do in practice. So that's evidence-based practice. What we've done by creating an evidence-based practice model is write a book that reflects what clinicians in the trenches really do when they're aware of the currently available evidence-based treatments and interventions. So we've integrated all that knowledge, and we've created a curated collection of these interventions, again, for flexible use with your patients. So that's what the integrative piece of integrative modalities therapy means. The modalities word in the title of the treatment refers to the fact that these interventions are split up and organized into the 3 treatment modalities of individual therapy, group therapy, and family therapy. So in treatment, particularly at higher levels of care, there never really is one treatment modality administered. It's not just individual therapy. It's individual therapy, group therapy. Your family's coming in to have family sessions. And so we thought that it would be best for clinicians to have resources available for each of those different kinds of modalities. This can also be used in outpatient. So if you're familiar with dialectical behavior therapy, or DBT, DBT has what we'll call a bimodal, or two modalities that comprise the treatment. So there's individual therapy and group therapy. And patients with borderline personality disorder who come in for treatment in outpatient settings for DBT are enrolled in both individual therapy and a skills group concurrently. So there is a precedent for multimodality treatment, and we thought, why not for eating disorders? It makes sense that there would be individual, group, and family treatment occurring. Why not make those evidence-based interventions available to clinicians who are practicing within those different modalities? Because those different modalities target different aspects of the disorder and help patients in ways that just a single modality such as individual therapy can't really accomplish. For instance, we have carers or parents, guardians, etc., of people with eating disorders who really need to play a very supportive role in helping a person recover from an eating disorder. So what can we do to best support carers? Well, Dr. Hirsch and I thought that it would be a good idea to make handouts readily available for therapists to provide to carers as well as patients that have very common and core treatment concepts clearly written out, so that the therapist isn't verbally reinventing the wheel in every session, and instead can provide a handout that has all of the relevant information for the carer and the patient available. So what this can really do for carers is help crystallize the important information from a session, and if they need help referring or remembering the different treatment concepts presented, they have a collection of handouts, and if they're organized, a binder of handouts to refer back to. So the idea here is that we've integrated these different interventions into these modalities, and eventually it became a whole treatment unto itself. So the journey of IMT was not a linear one, nor was it traditional in the sense that I don't think a lot of other evidence-based kinds of practices or treatments have evolved in such a way. So what Dino Hirsch and I felt that we needed for our patients was we needed written material. So we started creating written material for our patients in group settings and also in family treatment, and using them in practice. And what happened was that lots of people had kind of heard about what we were doing or seen the handouts that we had given to patients, and they contacted us wanting to get a hold of these resources. I think the reason why this was happening is because resources, at least pre-2019, are very sparse for patients and carers with eating disorders. There are treatments that clinicians verbally administer, but there aren't, again, these written handouts with all of these concepts kind of laid out. So what we decided to do was start developing these collections, these curated collections of interventions into a cohesive treatment manual. And that manual is this, Treating Eating Disorders in Adolescents, published by New Harbinger. And the resources for patients and carers in the individual, group, and family modalities are available for free on the New Harbinger website. So I can provide you the URLs and all of that in the bottom of this screen. So if you just check that out, you can find where to purchase the manual and the PDFs. Okay, so what else? Why IMT? So we wanted to create IMT first and foremost because eating disorders are the most deadly of mental illnesses. eating disorders directly impact your body, your physiology, its functioning, and could lead to a whole host of problems, including death. So understanding that eating disorders are such a problem, coupled with this idea that there really weren't so many accessible resources available, I personally felt very compelled to go in this direction as a career. I didn't set out in my career wanting to treat eating disorders. In fact, I thought that they were pretty scary to treat and wanted to kind of avoid it until I really recognized in practice what a huge problem these disorders present, and again, how few resources there were out there. So it really was a very compelling diagnosis to want to jump in and try to help solve in some way. Not that we're going to solve eating disorders totally, but there are many efforts by wonderful colleagues out there to decrease eating disorders, and we wanted to contribute to those efforts by making this manual and the resources available to clinicians, patients, and carers alike to streamline the process and of treatment and make it hopefully easier and comprehensive. So in addition to the deadliness of eating disorders, there was a challenging aspect to them in that they're what is called in the psychodynamic and psychoanalytic literature egosyntonic. So what does egosyntonic mean? Essentially, what egosyntonic means is that a person doesn't necessarily appear as if they want to get rid of the eating disorder or disorder, whatever disorder it is. They might, in fact, even not be aware that they have a disorder. So, for instance, a person with an eating disorder can come into treatment with a medical doctor, and the medical doctor could say, your labs look like you're about to have a heart attack, and this is because you're restricting your food intake. And rather than taking what that doctor says at face value, a person with an eating disorder might interpret that as, oh, I'm about to have a heart attack. That means I'm eating too much cholesterol and I need to restrict my food even more. It can't possibly be that I'm not eating enough. It must mean that I'm eating too much. So an egosyntonic disorder is one that a person may not even be aware that they have, nor do they appear as if they want to change it. Within IMT, we've rebranded and reimagined what an egosyntonic disorder is, and we call it a self-eclipsing disorder. This term comes from a family-based therapy or an FBT concept that shows a Venn diagram, and essentially the eating disorder circle is eclipsing the self circle. So from this Venn diagram, we had the inspiration to call egosyntonic disorders self-eclipsing disorders, because that's really what happens. The self is still there. It's just that the eating disorder covers it up, or the disorder covers it up, and the person can't really access themselves in the same way that they used to, and they appear to not want to get rid of the disorder. Do we assume that people, just because they say that they don't want to get rid of the disorder, don't want to get rid of it? No, we don't assume that. We assume that there's a person deep down inside that wants to be healthy and doesn't know how to be, and is hurting their body and psychological mindset in the process. Both of those become compromised. So we employ interventions to help the person become self-actualized, meaning or self-acknowledged, rather, self-acknowledged. So we help people to become self-acknowledged, meaning they acknowledge that a self is there and that the disorder is impeding their access to themselves. So within this framework, it's a little bit easier to understand what interventions, from our perspective, to employ to help. But egosyntonic, or in IMT lingo, self-eclipsed disorders present is the issue of the fact that the person doesn't necessarily come into treatment all the time wanting to recover, or saying that they have goals that are in line with recovery. So This is a pretty big obstacle to overcome, and I think that as evidence-based practitioners, we need to think pretty flexibly about how to employ the interventions that we know to be helpful to the treatment of self-eclipse disorders or self-eclipsing disorders. So one of the things that we really advocate in IMT is the pointed use of reinforcement. So we know through about 100 years or more of research in behavior therapy that reinforcement can shape behavior over time. And as behavior gets shaped over time, thought processes then change. So we employ, for instance, reinforcement around completing meals, selecting challenging foods, engaging in behaviors that are in line with recovery, and the like, because those kinds of external reinforcements can help a person to become self-acknowledged in the context of a self-eclipsing eating disorder. So that's one idea about why IMT is a bit different from what's out there. Is it acknowledges that self-eclipsing eating disorders or disorders are difficult to treat and attempts to, from within an evidence-based framework, directly target that kind of symptomatology. So IMT is pretty different, again, than what's out there, even though all of the different components are already out there. We'll say the whole is greater than the sum of its parts in this instance. And the parts are meant to, again, be used flexibly in this a la carte fashion to help meet your patient's treatment needs in whatever setting they are in. So if that setting is an inpatient hospital, you can use, for instance, a group intervention, a standalone group intervention during a group that a patient may only attend a couple times. So the skills don't actually all build on one another. Each IMT intervention can be delivered individually because we know, particularly on inpatient units and in partial programs, for instance, that patients may not stay for an extended period of time. Maybe they'll only be on the unit a couple of weeks and therefore go to 6 groups or so. So they can't necessarily learn skills in a way that is cumulative. They must learn skills on a very rolling admissions basis where people are constantly rotating in and out of groups. So again, we've created each IMT intervention to really stand alone and be helpful to patients at all levels of care in different settings. So I think that IMT is rather different from its predecessors in that capacity as well. So with DBT, for instance, a wonderful treatment, the best treatment for borderline personality disorder and other disorders out there. That said, the modules are really written for outpatients rather than inpatients. And this means that there might be, for instance, 4 groups that all build on one another, and then a patient can be admitted on a semi-rolling basis because they have to wait until that module was completed. So IMT does not work that way by design because so many people with eating disorders must receive treatment at a higher level of care due to their medical conditions. So a person with an eating disorders treatment might not look the same as someone with another disorder because their treatment starts at inpatient, and if the person, for instance, has anorexia nervosa, they might need to be weight restored at the hospital, and that could take, I don't know, it varies, but let's just say it takes 12 weeks. So if a person is on an inpatient unit for 12 weeks, they then rotate to different treatment settings before they reach an outpatient level of care. So they might go from inpatient to residential to partial, and then eventually get treatment once a week. So in all of those different settings, treatment is going to be chopped up. It's going to be delivered potentially by different teams, most of the time different teams, and it's not standardized in any way. So what we really felt was important for our patients with eating disorders is to develop a set of interventions that were standardized and could be used across settings. So what does standardized mean? Basically, remember how before I was talking about therapists verbally reinventing the wheel? Well, rather than each therapist having to verbally tell a patient the same treatment concepts, we would be able to know based on what handouts the patient's received in treatment, what the patient has learned before, and in the next treatment setting where their education essentially needs to be supplemented. So let's just say on an inpatient unit, the patient received all of the CBT group handouts. Great. Now, in their next treatment program, maybe they'll have to receive the mindfulness and acceptance handouts because they didn't get those in the previous treatment setting. So it really is meant to be administered, again, as needed. And a person is supposed to be able to track, a clinician and a patient, both people, need to be able to track what has occurred in treatment over time. And each, let's just say, each different, in theory, treatment setting is using IMT. It would be really easy to know, again, what has been done and what needs to be done in the future. And it also standardizes the way in which information is being communicated. So a therapist might verbally tell one patient one version of the skills and verbally tell patients another patient another version of the skills. Whereas with the handouts, everything is written, it's all right there, and every patient has access essentially to the same content on a given handout. Now, not every patient needs every single handout. There are some cases where a patient might only need a handful of handouts, and other cases where patients will receive almost every handout in the IMT manual. And that's fine. It all depends upon what the patient needs. That said, if a patient is receiving an intervention, that intervention is standardized because it's the same information on the same handout, and it's not verbal. Again, it's written. I think you guys get it. So IMT is different than its predecessors in several ways, and yet, again, it's made up of these evidence-based components. So that's basically IMT in a nutshell. There's a lot more to get into about the specifics of each intervention within each modality, but for now, I think that's about enough. If you have any other questions, please feel free to reach out to me. I've gone through lengths to make myself very accessible and make the IMT material very accessible. So we have, for instance, if you're a clinician interested in learning IMT, we have a LinkedIn group and we have a Facebook group. And these are closed groups for clinicians. And the idea is that if you have a question about eating disorders or treatment or IMT specifically, you can post that question in that forum, and myself or somebody else that's familiar with IMT and the treatment of eating disorders will be happy to answer your questions. We also have a website, and you can contact us with the contact form directly from that website, and it goes straight to my Gmail. So I'll get the email if you send it through that contact form on the website. And we also have some other shingles out on the internet where you can follow along with IMT posts. So we have an Instagram account, a Facebook page that's separate from the closed Facebook group, and we have a Twitter page. Also, I have specific pages as well. So I have a Twitter page, and I also have a LinkedIn account. So with all of those options available to you, I hope that if you have a question, you'll be able to get in contact with me or someone that is very familiar with IMT. Thank you so much for your attention, and I hope that IMT is helpful to you, your patients, and their families. Thank you so much. Take care.